Welcome to Bear in Mind, the Brown Psychiatry Podcast, clear, current content about mental health. I am your host, Dr. Tracey Guthrie, Psychiatry Residency Program Director and Co-Editor-in-Chief.
I'm Dr. Camila, Cosmo, Brown Assistant Professor and Co-Editor-in-Chief.
And I am Dr. Madison Pomerantz, Psychiatry Resident and Script Editor for today's episode.
And I'm Dr. Jessica Pineda, a reproductive psychiatrist.
First, a content warning.
In this episode, we will be talking about sensitive topics, some of which you may find triggering. Our only purpose is to provide education and information. Our content is not to be considered medical advice. Pregnancy can be a time filled with joy and anticipation, yet it is also marked by uncertainty, which can sometimes lead to feelings of being overwhelmed or anxious. Pregnancy was once thought to promote emotional well-being and protect against the development of psychiatric disorders. However, recent studies have demonstrated that significant percentages of pregnant people experience psychiatric disorders during pregnancy.
Accessing treatment and accurate information can be particularly challenging. It is important to understand the risk factors for developing psychiatric disorders during pregnancy, strategies to optimize mental health, symptoms that warrant reaching out for support, and treatment and resources that are available.
To help us discuss this important topic, we are excited to have an expert in the field with us today, Dr. Jessica Pineda. Dr. Pineda is an attending physician who is dual-boarded in family medicine and psychiatry and an assistant professor in the Department of Psychiatry and Human Behavior and Family Medicine here at Brown. She's a specialist in reproductive psychiatry, and we are lucky to have her join us today. Welcome, Dr. Pineda.
Thanks for having me. It's good to be here.
Yes, welcome, Dr. Pineda. Very good to have you. Thank you. So as we were saying, some think of pregnancy as a time of euphoria, a time of rainbows and sunshine, and a time that's protective against psychiatric disorders. Is this true? And how common are mental health disorders in pregnancy?
Well, I would say probably not protective. What we see, so when I'm really thinking about the perinatal period, we're thinking about pregnancy up to 1 year postpartum. And we are finding during that time that as many as 1 in 5 women may develop some sort of mental health disorder. So that's over 500,000 women in the United States per year, right? And that can occur anytime during pregnancy or the postpartum period. And the postpartum period being a particularly high-risk time for worsening symptoms, or even for individuals who've never had any other psychiatric history before, any kind of symptoms may develop new symptoms within those first few months postpartum. Mm-hmm. What I would say, though, when we think about protective, I mean, there is some value to being pregnant. We do see that women tend to have less inpatient psychiatric admissions during pregnancy. We find fewer death by suicide during pregnancy. Mm-hmm. However, in the postpartum period, this becomes a very high-risk time for death by suicide. It can be very dangerous. And we also see increased admissions to psychiatric hospitals in the postpartum period. And this elevated risk can continue for up to 2 years postpartum.
Mm-hmm. Dr. Pineda, what are common psychiatric disorders in pregnancy? And how might someone recognize if a loved one would benefit from help?
Mm-hmm. You know, I think we often think about depression in the perinatal time and certainly postpartum depression. So individuals feeling sad, down, not having a sense of happiness, suicidal thoughts. And it's estimated maybe about 17% of women may develop postpartum depression. And postpartum depression can be associated with significant anxiety. There's a lot of anxious distress associated with major depressive disorder. And also remembering that some women don't experience depression. There may be other symptomatology that occurs in the perinatal period, which can include anxiety without depression. Specifically, there can be some moms that can have some really intrusive worries about their infants. Can be followed by lots of checking, a lot of concern about infants' health. And we often think about this as an almost OCD or obsessive compulsive disorder-like phenomena. Women may be experiencing bipolar disorder, having worsening symptoms surrounding that, sort of activity, impulsivity, irritability, or even more rarely, but we can see in the postpartum period increased rates of psychotic symptoms, confusion, loss of touch of reality, maybe hearing voices, having delusions. And, you know, I think it's good to be aware of those symptomatology. And the symptoms become a problem, and I talk about this to everybody, when they become dysfunctional, right? When they get in your way, when they are inhibiting your ability to enjoy your baby.
Right.
When you're not able to sleep even when your baby sleeps, right? We're all sleeping less when we have new infants at home. But if you can't also sleep when that infant is down in their bassinet or their crib, that's a problem, right? And then certainly if there's any thoughts of hurting infant or hurting yourself, these are reasons to seek out for help.
So as a follow-up question to that, are you saying, Dr. Pineda, that someone could develop these symptoms of sort of like OCD or depression or anxiety or psychosis when they never had these symptoms before? That this is something that may develop after the birth of a child? Is that something that
Absolutely, yeah. And we really think that first 90 days, we're seeing a lot of women with new onset symptomatology in that period. And so I think there's lots of reasons as to why that might happen, right? Hormonal changes, timeline. Many women are having babies at the time that we do see new onset symptomatology in the early 20s. And is this just sort of like that additional stressor that moves someone into one of these disorders?
And is it possible then to see resolution? Do you see that people have these symptoms postpartum, they get treated, and that they don't have any of these continued symptoms of OCD or depression if they're treated appropriately, and that they may be monitored for it if they're going to have another child? Is that something that you see?
Absolutely. I think it's really important for everyone to know that there's excellent treatment for this and that people can get better. And also, becoming a mother, having a child, becoming a parent, it is a new piece of your life, right? And so I do think there is also this finding that perhaps there's a new level of anxiety that you're going to be managed. And there are these other new things that are happening in your life that you weren't dealing with when you were before parenthood, right? But I think it's very important. Yes, of course, women get better. They do get better. There's excellent treatment for them.
Good.
And Dr. Pineda, I'm wondering if you can talk about what the risks are of untreated mental health disorders in pregnancy for both the pregnant person and the fetus.
That's a great question. And I think when I have individuals come to my office and we are talking treatment planning about what they would like to do, I always start with, here's what we do if we do nothing. I think it's really easy to forget that that is also a decision and that is also a risk, right? And there certainly is evidence showing complications in pregnancy, and that can include earlier delivery, elevated blood pressure, preeclampsia. Infants can be born smaller with lower weight. And I think what we find really consistently is individuals who have perinatal mood disorders tend to be less successful in breastfeeding in the postpartum period. What I focus a lot and what I really am talking to my moms about is that if we do not treat you now while you're pregnant, that your symptoms will likely worsen in the postpartum period. And we see that repeatedly, and I see that. And so really much of our motivation for moving into treatment in pregnancy is to get you well for when this baby comes. We know that it will get worse. And what happens if you feel poorly in the postpartum period, right? That has complications. That has complications for you. You're a mother, you're a parent, you deserve to feel well. There's no value in suffering for your child or for your family. It doesn't help them, right? And we already talked a little bit about the risk of suicide. And so reminding them of that. But moms are we're very worried about our children and we want to do everything we can to help them. And so the additional thing that we talk about is what happens if we are not feeling well postpartum. And we have a lot of data that can really impact children. So when you are feeling sad, when you're feeling anxious or whatever way, it is difficult to attend to a child's needs, a baby's needs, an older child's needs. And that can really impact the attunement or the attachment that you have with your child. And what does that do down the road, right? And so that can impact your child's academic performance, their socialization, their own behaviors, their own mental health, right? And so to help that, to prevent that, we want mothers to be as well as they can when these children come, to help with the attachment and the socialization of their children.
So how do you think treatment for psychiatric disorders, how do you think about that? How do you make decisions about what medications to give, what evidence-based treatment exists, and what about breastfeeding?
Yeah, it's a great question. And I think it's a complicated question. I think it is an individualized question with each patient that comes in. And so, they come in, and I think what I love about treating people during this time is women are so motivated, right? I think we see a lot of people come through our doors that have really suffered for a long time, right? And now they're pregnant and they're like, okay, I need to really be the best, healthiest person I can be. And so there's a number of evidence-based options that we can use. For mild to moderate symptoms, therapy is a great option. Therapy has very little risk to the pregnancy. There's very little exposure, and therapy can be incredibly valuable. When we look at the studies, they talk about two different kinds, which is CBT, cognitive behavioral therapy, which can have really great outcomes, as well as interpersonal psychotherapy. And interpersonal psychotherapy, specifically for the perinatal period, focuses a lot on role transitions for moms, right? So you're like in this new role, the way that you interact with others may be different. The needs you have from your partner or your family might be different. And so really working how to navigate that and communicate that. And also sort of grieving maybe the loss of a previous role that you had and sort of really learning how to enjoy this new role that you're entering into.
Mm-hmm. So, I mean, I think this is an extremely important point because this is where a lot of people are trying to make their decision. So let's try to give them some information to help them. So what medications exist that are out there that people can use? And how do you think about that in a risk-benefit analysis, and specifically about breastfeeding? Because that's a question that a lot of parents have.
Mm-hmm. Yeah. So if I have somebody coming in, we're discussing medication, right? Either starting new medication or continuing medication. We are really balancing the risk and risk, right?
Yeah.
So people come into my office and they want zero risk, right? And all, but like the time you've met me, this isn't a risk-free pregnancy anymore. And so the role of the medication and the conversation I have is really balancing that risk, right? How can we mitigate the risk of all the things I talked about before, an untreated illness or an undertreated illness, with any risk that a medication may have? And I would say that there are very few medications that we can't use in pregnancy, right? Mm-hmm. I think there are variations of medications that have more data, that have maybe more or less risk for some complications or some things to monitor, but there's very few medications that like absolutely not. We have options, right? And so it really can be a very individualized discussion with patients, but that is how I frame it. So I talk about here's what happens if we do nothing, here's the risk we run, and here are some of the risks with the medications we're using. And what we want to be is really thoughtful. We want to think about using medications that have worked before, right? Yeah. I think a lot of people think about Zoloft in pregnancy and breastfeeding, and that's an excellent option that has lots of data. But if that's not a medicine that works for you, that's not the medicine we use, right? And we have lots of medicines, especially in that class, which are the SSRIs, that really have very good safety data. And as we're thinking about initiating treatment in pregnancy, we also want to be thinking about what can our moms use to continue if they want to breastfeed, right? Mm-hmm. And so there would not be a scenario where I would say, use this while you're pregnant, and then we're going to switch you during this really high-risk time in the postpartum period and see if something else works, right? And so the breastfeeding really is a part of the conversation. And I would say many of the medications that we use are compatible with breastfeeding. We tell moms to monitor things like eating, weight gain, and things like that, but can be really compatible. And if I am having a mother take a medication during pregnancy, I'm thinking about that. I'm anticipating they might breastfeed. And I don't want them to stop breastfeeding because of a medication, right? And or pump and dump or any of those sort of things. Yeah. So I think it is all a part of sort of that initial decision with starting or continuing a medication.
Mm-hmm. And Dr. Pineda, could you comment briefly about the medications that would be concerning for someone that is breastfeeding, that would require attention, that you would recommend against that?
In breastfeeding?
Yeah.
It's actually a really hard question. I don't know that there are many. Mm-hmm. I think that every medication, never say anything's risk-free, right? We always want to give some anticipatory guidance. I think some things are incredibly low risk, like most antidepressants. There's some medication that could be sedating. And I think that if I ever have a conversation about monitoring breastfeeding, it almost always involves sedation, really reminding mothers that it's not recommended to co-sleep in the context of having especially a sedating medication on board. But I think moms have a lot of great options when it comes to breastfeeding.
Good. And for someone that is listening to us now and has a condition, depression, anxiety, and find out that they are pregnant, what they should do concerning their medication regimen? Should they continue taking it? What would be your advice for the next steps?
So my advice is do not suddenly stop your medication, right? And that doesn't mean that they should continue it necessarily during their pregnancy, but suddenly stopping the medication really puts people at risk for rebound symptoms, right? And so I think the first thing they should do is call their doctor, right? Call the physician that they're working with, whether that's psychiatrist, primary care, and OB, and have a conversation about this medication. And that conversation should not just involve the medicine, right? So that conversation should involve everything we talked about before. Like, what are your risks? What is your own psychiatric history? Have you been well for 5 years and not had any issues? Or are you still feeling poorly right now? And these sort of things can alter the decision on whether or not we continue or try to taper off a medication.
That makes a lot of sense. And Dr. Pineda, I'm wondering, if somebody is listening to this and thinking about becoming pregnant in the future, I'm wondering what some key risk and protective factors might be that influence the likelihood of the pregnant person developing a mental health disorder during pregnancy.
Yeah, I think that there is a long list. I'll start with the first ones, which are always the easiest, which is a history of it, right? So if you've had a history of having trouble in pregnancy before, I think that elevates your risk. I don't have a specific number for anyone, but I would say that that is a big risk factor. Having a history of a mental health disorder can also elevate your risk, and I think is worth coming up with a plan on how to manage those things, right? And then other things that can really put people at risk are unplanned pregnancy, financial stressors, violence in the home, and certainly complications during your pregnancy. If this has been a hard pregnancy, that can elevate our risk for mental health disorders.
So I have a two-part question about your support network. Let's talk a little about families. Let's talk about the role of family, because if you have family around you during this time, they can be very helpful. What would you say to families who are noticing symptoms in someone who is currently pregnant that they're concerned about? And maybe the person who's pregnant, the identified patient, doesn't see them, doesn't think that there's anything that's a problem. What should families do? You've got people talking about it behind the person's back. They're afraid. What should they do? How can we empower them to take a step to help?
Yeah. I think the most important thing for a family member to do is address it, talk to the individual. I think it is hard to help somebody if you're not kind of honest with them and talking to them in a very caring way. Like, we are worried about you. We see that you're struggling. We want you to be well. And there is a lot of help. You can feel better. There's a lot of treatment options. And also that this is not uncommon. Right. A lot of people struggle. And it is also not a failing of being a mother. And we can hear that a lot of guilt, not feeling good enough, confusion, feeling like no one else, this isn't a problem for anyone else. Why me? What am I doing wrong? And that just simply isn't true. And so I think having a conversation with them in that way can be helpful. I think offering to join them in a conversation with their physician, offering to help make those appointments can also be really helpful, because that's a very intimidating thing to do. I know sometimes when I'm at the doctor, I'm like, everything's fine. Yep, all set, right? I think, and so I think it can be really, nothing to see here. I think it can be hard to, articulate that for some individuals. And so having a family member with can at times be helpful.
Yeah, well, certainly that statistic, 1 in 5, helps put into context for people that they're not alone. And there's a lot of people that struggle with this and go on and have perfectly beautiful and healthy children.
Right, who they love and take really good care of.
Take really good care of.
Yes, absolutely, yeah.
So where can people find reliable information about psychiatric disorders in pregnancy?
Yeah, so you can get onto the Google page, but when you do, what I would encourage you to look into is Postpartum Support International is a great organization. And on there, they can have information for people. You can connect with another woman who maybe or an individual who's gone through similar things. There are support groups for family. There's LGBTQ plus resources. There's also resources to find providers in your area. So I really like that resource. There's also Mass General has a women's mental health blog, which I think has maybe a little more in-depth information about different medications or other challenges. Mother2baby.org is great for kind of referencing medication risk specifically. And so those are some of sort of, I think, immediate resources people can look into.
So it's www.postpartum.net.
Thank you so much.
Is the website. Okay, that's really wonderful. Thank you.
Yeah. And for someone that is local in Rhode Island, What are the services that we have available to support our patients?
Yeah, Rhode Island is really lucky because we have a lot of folks. I think, my office at Women's Behavioral Health, we see people, therapy, meds. We have a partial program for women who are struggling with any sort of symptom in pregnancy, postpartum, and IOP for OCD, because again, that is so common in this time period. There's also the Women's Collaborative, which is a part of the Lifespan Group, which sees people similarly. And then there are a lot of reproductive folks in the community. And I would also say probably a lot of general psychiatrists as well who are well equipped and well educated in this field coming out of these programs.
What proactive steps can people take if they are contemplating pregnancy in order to optimize their mental health for a health and supported pregnancy experience?
Yeah, that's a great question and sometimes challenging one for me to answer, actually. But I think you got to know your risk, know your plan, right? If you have a history of a mental health disorder, if you are currently struggling, I think having a good plan is really important and getting yourself well. This is also a time that if you're not feeling well, you can engage in treatment, getting a therapist if you don't already have one. I'll tell you, I had a patient once tell me, which is really helpful when I was pregnant, right? Some unsolicited advice, but very helpful advice after we'd had a very in-depth conversation about what was the right stroller to get. She told me, I wish that when I was planning to have my baby, I had thought less about that and more about who I was going to have to help me.
Yeah.
And really recruiting social supports. And I totally agree with that. And I think it also poses a unique time for women where they are maybe asking for help in a way they have never had to before, right? And really successful, high-achieving individuals. And I think that's a skill that they may not have learned. And I think also the other thing to think about is what kind of people you have to set better boundaries with. Maybe people really asking what you need and what you don't need and being able to articulate. That's hard to do. So I think that is such great advice. And in Rhode Island, there's options for doulas, which I think can also help navigate the pregnancy and the postpartum period. It can be really valuable. Most insurances, I believe, cover this now. And so I think those have always been really good advice. I also think that we, as people that maybe aren't having children, how can we help women who are planning a pregnancy? And there's a lot of data showing that financial burdens or financial stressors, that lack of affordable childcare can really impact maternal mental health. And so thinking about how we can get, paid family leave for women and their partners, right? How can we have affordable healthcare places for women to go? How can we get them to specialists? How can we decrease that barrier? Because it can be hard to find therapists and mental health providers in some areas.
Thank you, Dr. Pineda. It's an important consideration for us to all be thinking about. And I'm wondering if you can talk about some key self-care strategies, including considerations for sleep and other important aspects that pregnant individuals could prioritize to improve their mental health.
Mm-hmm. Yeah, that's a great question. The thing that comes to the top of the list, which I imagine that you're going to know I'm going to say, is sleep, right? Mm-hmm. And that is so hard. You don't sleep much when there's a new baby at home. And that can be a really hard thing to do. And so I think figure out a way to get some hours of sleep. It's a very specific suggestion, something I tell my patients, is maybe split up the nighttime duties, right? So from 8 p.m. to 1, you take the shift. You do the feeds, you take care of baby when they get up. And then from 1 to 6, your partner does the same thing. I think there can be some logistical issues surrounding nursing if that's happening, but that's just one example. So I think prioritizing sleep. I think eating well can be really, really important. I think getting some movement, right? So getting out, walking, doing whatever kind of makes you feel good can be really valuable options.
Mm-hmm. This has been very helpful. Thank you so much. I do think that it's important for us to talk about what if someone is so concerned about their loved one that they're concerned that they might hurt themselves or someone else. What steps do you think that they should take?
Yeah, so I think that you talk to the individual for sure. And also they can use any emergency line, right? So 988 is very helpful and can help people through acute emergencies. And you can get them to the nearest emergency room if there's an acute safety issue, right?
So I think the other thing is I do want to emphasize what you said. I don't think that you gave enough credit to what we do have here in Rhode Island, which is a large portion of what you guys offer Women in Infants Hospital. It is impressive. It is a significant benefit to the people of Rhode Island and nationally, because you guys also assist and try to educate other people outside of Rhode Island. So your reach has certainly grown. Yes, every resident here goes through your program. Yes, they come in. Some of them come in, know that this is what they want to do. Some of them wind up really loving their time here with you guys. And some of them choose to do it for the rest of their career, like Dr. Pomerantz. This is her area of expertise. This is her specialty, and she's going to go out into the world and help a lot of women and also educate a lot of other doctors. I do think general psychiatrists are better trained in this area when we have this sort of access. But thank you for doing all of that work locally and nationally. It really does make a huge, huge difference in the lives of women.
Great, thanks. It's a pleasure.
So Dr. Pineda, we've talked a lot about what the postpartum period can look like and how challenging it can be for a lot of people. And, something that can be so common is intrusive thoughts, obsessive thoughts about harm coming to the patient themselves, to their baby even. And I'm wondering if you can talk a little bit about that and what that means in the postpartum period.
Yeah, that's a really important question, because there can be times when thoughts of harm to infant is very dangerous, and certainly times where it is very distressing and not dangerous acutely. And so when we think about these two things, so in postpartum OCD, which is very common, 3 to 5% of women, right, may have intrusive images, thoughts of hurting themselves or their children, right? Incredibly distressing to the mother. They'll be very upset, maybe reluctant to reveal that to us at some time, but may present in other findings, right? You may notice the parent won't leave baby, doesn't feel comfortable leaving them with anybody. Maybe they stop sleeping because every minute they need to go check on that baby, right? And these types of intrusive thoughts, while very distressing and upsetting, are not associated with harm to children, are not associated with harm to mother. Now, we compare that to something that we can see in psychotic-like illnesses in the postpartum period, or postpartum psychosis, as we refer to it. And that can be associated with thoughts of harm to the infant. That tends to be correlated with less distress, right? And there would be other symptoms of psychosis, confusion, maybe like very internally preoccupied, seeming like they're talking to somebody that's not there, or like really preoccupied with their thoughts, may be confused about the day or whose baby this is, or other kind of like delusional type symptoms, right? And so the mother may not be acting themselves in these moments, and that is an emergency. That is a reason to bring them to the emergency room and get them to the emergency room. And understandably, people don't want to go, right? And those are really hard scenarios, but they're very important times where we get our family members there, and we can call 911. The Providence Center actually has a crisis line here in Providence where social workers will come out, and they can also assist and navigate some of these things. But it is very important that they get seen immediately, because that can be very dangerous.
Are there other scenarios that you want to let our listeners know about, that these are times you really need to seek help, get someone to an emergency room or possibly inpatient care?
Yeah. So if individuals are making comments about killing themselves or dying, think that they're better off dead. If they have had plans of how to do this, right, and are at imminent risk where that might be happening, those are reasons to go to the emergency room. And similarly, you're wanting to send them for help, right, and get a plan in place. And if that's not able to happen, you can call 911 or, again, a crisis line to help get you there.
And we've talked about this several of times on this podcast, but this is not a time to have firearms around at home. These firearms need to be secured, removed from the home when someone is struggling with a mental health crisis. This is not a time for that person to have access to firearms. So be a responsible gun owner and remove that access for someone before irreversible decision is made.
Yeah, absolutely. And I think that that's like a concrete thing that folks can do if those means are available on the whole.
Yeah. So, Dr. Pineda, you were mentioning about those scenarios where people might need to go to the ER. Could you clarify which are those circumstances where people would need an inpatient level of care? And also if you can comment on the different levels of care and what they would entail?
Yeah, of course. Yeah. So the emergency room evaluation for someone who's having lots of harm or concern about being safe, if it is deemed that there is not a safe plan to go home, so this threat is so imminent and so risky, those are times that we recommend an inpatient admission. And that admission looks like coming to an inpatient unit like Butler, where individuals are stabilized, right? Number of days, likely for many people, where we can like assure safety, right? Maybe get them feeling a little bit better before they head home. And that is so important. Mothers must stay safe, right? It is so challenging to think about being separated from your infant, right? We don't want that at all. And also, if we don't keep you safe, it's all for naught, right? And so I think that those are the scenarios with which we recommend inpatient admission. Our office, understanding we want to keep individuals together if there is not this imminent risk of safety, right, where we can stay home and stay safe, we can offer a partial hospitalization. And that is and there's opportunities in our office to do that. And that is sort of women come in during the day, typically from about 9 to 2:30 or so, and they come with their infants. They're either pregnant or they come with their babies. And it's an opportunity really to get better while caring for your baby and kind of work on those skills as well. There's other women there who may not have your exact same symptoms or exact same struggles, but are having struggles. And I think that there's a lot of value in communicating with women who are struggling like you are. You feel so much less alone. It's so much more validating to have that. And so that is programming that we have that is programming that we offer at our office.
Yes.
Additionally, we have an intensive outpatient program for OCD. And so this meets 3 times a week for a number of hours. And this really focuses on the treatment of obsessive compulsive disorder, which, like I've mentioned, can be relatively common, especially in the postpartum period. And doing group therapy and doing exposure response type of therapy. And that program lasts longer. We don't do it every day, but typically it's about 6 weeks. And so it's another offering for intensive treatment for women who are struggling. And that's in addition to our outpatient offerings with therapy and med management.
Excellent. Thank you.
You know, something we didn't address is that I'm sure people have heard about is the treatment for postpartum depression, the infusions that are available. So I think we need to tell people about that, because I'm sure they've been hearing about it, have heard about it in the press, and are sort of wondering about that.
Yes, absolutely. Thank you for bringing that up. So there currently are 2 FDA-approved medications for postpartum depression, and those are brexanolone, which is an infusion, and zuranolone, which recently came on the market, which is essentially an oral version of that infusion. And just to talk a little bit about what those medications are and what they're doing is the idea in pregnancy is as you become more and more pregnant, all your hormones are going up. And then you have your baby and they go away. Right. And for a certain group of individuals, that is probably really destabilizing. The receptors just have a lot of trouble kind of adjusting to those changes in hormones. And that, we believe, in some women can present as postpartum depression. So these medications are sort of an analog or similar to a progesterone metabolite called allopregnanolone. Again, goes up, and then suddenly drops off in the postpartum period. And so brexanolone is a 60-hour infusion, which we do at Women and Infants Hospital. So women come in, they are admitted, they get their infusion, and then they go home. And what we find is that it can really treat postpartum depression into remission for months at a time. It's really very amazing. Recently, but it can be challenging, right? Because you have to go to an inpatient hospitalization, you have to spend time away from children, you have to find childcare.
It's not done everywhere. It's not available.
Yeah. We're one of like the few hospitals, I think, that is doing it. And so we are lucky now that zuranolone, which is an oral version of the same sort of treatment, which you take nightly for 2 weeks, which is having very similar findings.
Mm-hmm. Thank you very much, Dr. Pineda. This was extremely helpful. Now, a take-home message to bear in mind.
So we've learned that pregnancy is not as protective as we thought against the presence of psychiatric symptoms or disorders. In fact, pregnancy and the postpartum period can be a time of great vulnerability. People with prior history of psychiatric disorders are even more vulnerable during this time. Treatment exists, and seeking professional help is important. When considering medications in pregnancy, it's crucial to consider all risk, including exposure to medications and risk of untreated psychiatric disorders.
There are safe and effective treatments that can be used in pregnancy and breastfeeding. Studies have shown that treating psychiatric disorders in pregnancy improves outcome for pregnant people and their children.
We hope today's podcast has given you a better understanding of psychiatric disorders in pregnancy to help you and your loved ones navigate pregnancy. And as always, if you or someone you know is feeling depressed and having suicidal thoughts, please contact the Suicide and Crisis Lifeline, call or text 988, or access 988lifeline.org.
Thank you for listening to our podcast. For more information and related content, please check out our Instagram, X, Facebook, and YouTube channels. Bear in mind the Brown Psychiatry Podcast. Thank you.
Thank you.